Hi, and welcome to the Camtasia on the osteopathic approach to the lower extremity, the integrated lower extremity exam. So a lot of this is going to be review for what you've had already, which is why we're doing this as a Camtasia. You can review online, and then we'll have a bit of a challenge at your TBL and put together some cases and see how you can use the knowledge of what you've learned last semester to be able to solve some cases and be able to add in some osteopathic concepts. So our objectives, we're really going to go over some overuse injuries today and what those stages are, understand some of the biomechanical causes for overuse injuries, talk a little bit about the difference between tendonitis and tendinosis, discuss intrinsic and extrinsic factors, describe lower extremity orthopedic tests and positive and negative findings, which you've done a lot of already in your doctoring class. And then we're going to integrate that standard orthopedic exam with how we're going to do our osteopathic exam. And they fit together really well and really easily. And so that's what I hope to help demonstrate today. We'll talk about some of the indications and contraindications to OMM in the lower extremity, a little bit of the research, and then we're going to talk about how we can create osteopathic treatment plans for a few of these overuse injuries like IT band syndrome, ankle sprains, patellofemoral syndrome, plantar fasciitis, and shin splints. So lower extremity overuse injuries, this is really due to repetitive trauma. So thinking about people like runners or gymnasts or swimmers, people who are doing the same thing over and over again. And there's really 4 stages: pain after the activity occurs, so after you finish running, pain during the activity, pain during the activity that you're no longer able to work through, and then chronic unremitting pain even when you're not doing the activity anymore. So you can see that's kind of a progression of how the injury happens. And in lower extremity overuse injuries, there's a mismatch between what the overload is and the recovery, and this leads to breakdown. And when there's breakdown, those muscles and tendons and ligaments can't work and absorb tensions as they're supposed to. Next, we have, tendinopathy versus tendonitis. And what's actually the differentiation between that is that a lot of overuse injuries have more tendinopathy. So there's not really any inflammatory mediated cells there. It's more a dysfunction of the healing of the tissues itself. So they get edematous, but there's not any inflammatory mediators there. And they don't function the way that they should have functioned previously. So predictors of overuse: previous injuries. Anytime you've had a previous injury, you're more likely to have an injury again later, and running greater than 20 miles a week. And this is being seen a lot more in the pediatric population and teen athletes. Why? Because they're doing more and more sports. They're engaged in multiple teams at the same time. They're doing sports year round. There's not a lot of time for rest. And they're being pushed by their parents to do this. And not only that, but they might not understand that some of these sensations like fatigue in a body area or lack of performance that they've been able to do previously is really the beginning of an injury. And so they might not have the wherewithal, to describe that and be asked to be taken in. For lower extremity overuse injuries, there's intrinsic factors, so malalignment of bones and joints, muscle imbalances, inflexibility, weakness and instability, the tendinous healing capacity, and advanced age, which I'm very sorry to tell you is over 35, so clearly I am at an advanced age. But as we get older, our tendons and ligaments have a harder time healing, and so that puts us at a disadvantage when injuries occur or when we do these high load type activities. And genetics play a factor in this as well. People who have hypermobility syndromes or other kinds of tendon issues could have a harder time healing. And then there's extrinsic factors, so poor technique, poor running form, poor swimming form, improper equipment like shoes, training errors, too much, too soon. You go from running 5 miles one week to running 25 miles the next week. That's way too much of an increase in your activity. The volume of exercise, the load of exercise, the environment. Are you running on really hard surfaces, gym surfaces, carpeted surfaces, grass? Very different. If you've been injured before and you return too prematurely, you're more likely to have injuries. And even if you've been on antibiotics like fluoroquinolones, you're more likely to have tendinous issues or tendinous ruptures. So we think about biomechanical abnormalities that can lead to tendinopathy, especially in the lower extremity. And this is we go back to some of the lectures that you had last semester. So we think about posture, abnormal motion, we think about the podiatry lecture, the pes planus, pes cavus, and how either lack of pronation to be able to absorb forces or supination, which is too rigid, how either of those can lead to abnormalities coming, all those forces coming up through the lower extremity. Subtalar joint stiffness, reduced ankle dorsiflexion, which can lead to overpronation, muscle tightness and muscle weakness, like the lower cross sorts of pictures. Sacroiliac joint dysfunction, so thinking about, looking at our Mitchell model and how treating patients in the Mitchell model may help not only their ergonomics, but their biomechanical expenditure, right? How much effort they have to put into motion, and thinking about length tension relationships of muscles and fascia. And then even, this is more for upper extremity, but increased thoracic kyphosis, remembering back into our upper cross syndrome, that if we have a lot of scapular protraction as we elevate our arm, that can reduce that subacromial space because they're not functioning appropriately, and that can lead to impingement syndromes or rotator cuff tears. So biomechanics and the way things that are aligned are really important to these lower extremity overuse injuries. So again, ask yourself why. They don't just happen, right? So connect the dots. We're thinking about the lectures that you had at the end of last semester. So tensegrity, gait, posture, lower cross syndrome. And we're thinking again about structural versus functional lesions. So great, you've diagnosed someone with patellofemoral syndrome or plantar fasciitis or shin splints. Now, what are you going to do about that? Why did that happen? And certainly it could be because someone increased their training too quickly, but it could also be because of somatic dysfunction or these biomechanical abnormalities that can be addressed with OMT, addressed with a heel lift, addressed with orthotics. So be an investigator and don't just diagnose, but identify what's happening. Think of this overuse syndrome as a symptom, and you're looking for the cause. Why did this happen? And you also want to think locally and globally, right? I see so many people, someone comes in with foot pain, and even a good osteopath, all they do is look at the foot and maybe the lower extremity. But what's going on with the hip? Right? As we learned in our podiatry lecture, you can have glute medius weakness that could predispose you to overpronation. So you have to look globally. We're also thinking about autonomics. We're thinking about biomechanics. We're thinking about circulation. So it's why you really need to assess the whole body when you're thinking about these lower extremity overuse injuries. And OMT helps with lots of things. It can promote energy efficient and painless locomotion, which is a fancy way of saying when your body's all in line and when it's working the way that you are supposed to be, it's very energy efficient. You have the proper amount of energy expenditure. But when it's not, you have to create more energy expenditure. So we think about that in things with, or in patients with congestive heart failure, right? We want to decrease their energy expenditure so they can move more easily. But what about our athletes who really want to have peak performance? That would be a reason for them to get treated with OMT so that they can be the most energy efficient in their motion and in their athletic performance. We want to balance around the joints. Remember when we talked about the lower cross syndrome and we used the example of the knee, and if there's too much tension on one side versus the other side because we have muscle imbalance, that can lead to early arthritis or it can lead to tendinitis of one ligament or another. So we want to balance those agonist and antagonist. That's going to decrease the stress on the somatic structures in the lower extremity. We're going to balance that neural input. So all those afferents that are part of that sensory motor system, we bring balance to that by decreasing tension in certain areas. It can decrease nociceptive drive. So again, if someone's having a painful experience in an ankle and a knee and a hip, that's going to alter the way that they move. It's going to alter the way that they use that joint, which is then going to alter those spinal pathways. It's going to alter the way that they forever use it unless we change that for them. And it's going to cause decreased afferent referral from colon or pelvic organs, remembering referral pain, and it's going to promote effective venous and lymphatic return. And we're thinking about healing processes, right? And so OMT can definitely help with that. So when I think about the orthopedic exam and the osteopathic exam together, this is kind of the way that I think about it. So always starting with gait. How do they stand up? How do they sit down? What's their posture? Do they have foot drop? Can they heel walk? Can they toe walk? Do they have overpronation? Do they have oversupination? Do they have a leg length discrepancy? Do they have a scoliosis that I notice right as they're in there, as they're walking? Are they twisting their hip a lot when they walk? Does one of their knees bow a little bit more? Do they hyperextend as they stand? So there's lots of things that I'm looking at, just asymmetries from side to side as they move. There's some really funny walking patterns, and they're not like they have this big disease process or something, but we all walk and move in a particular way, right? Then we want to inspect. So we're always looking for redness, edema, warmth, any displacement, any muscle atrophy, varus or valgus. What position is that joint in at rest? And always comparing side to side. And then you're going to palpate. And I harp on this a lot because it frustrates me to no end when people are palpating, but they have no idea what muscles are there, what ligaments are there, what bones are there, right? So know what lives there. If you're palpating something, you should be knowing what you're palpating directly over. And like we emphasized in the podiatry lecture, a lot of the lower extremity muscles attach into the bottom of the feet. So if someone's having foot pain, you need to know what muscular attachment that might be. It's the same thing for all of the lower extremity muscles, and we're going to practice doing that a lot in lab. You need to think about the vasculature and the lymphatics, and then always active and passive range of motion and muscle strength. And people often confuse muscle strength with doing your neuro exam, which you want to do for most lower extremity issues, but also the strength around the joint. So making sure that you're not just checking your myotomes, but that you're also checking the strength of the hip in all planes of motion. And then range of motion, this is where your osteopathic exam gets a little bit more precise, right? So you're doing these major motions, and what we're going to talk about in the lecture today are minor motions, and that's what we're going to practice in lab, minor motions. So minor motions are going to be the big, what are all of these joints doing? This would be good test questions. And then the structural exam, of course, Mitchell model, lower crossed, special test is necessary. And then looking for the somatic dysfunction of the lower extremity. Is there joint restriction, soft tissue restriction, myofascial, tender points, trigger points, and then somatic dysfunction globally, right? Your ABCs, autonomics, biomechanics, circulation. So that's kind of how I think about it. So you've done a large part of this already, and I'm going to review some things, but you've done it. You can just skip it and fast forward through, what you've learned already last semester. A lot of it's going to be good review, good board review type questions of really common things. So make sure that you know this stuff for sure. So when we're thinking about the lower extremity lymphatics and vasculature, we're going to be thinking about sympathetics coming from T12 to L2, so that's always a great board question, and then innervation from L1 through S4, and always be thinking about the nerve root versus the peripheral nerve, which we'll get into a little bit at the end. And then lymphatics, of course, you're going to think about local lymphatics and then always thinking about the diaphragm. So I always think of, the plantar fascia, the popliteal fascia, the inguinal region, as you can see over here in the picture. So all the lymphatics come up towards the inguinal region. And so there's some release techniques, not necessarily for the pelvic floor, but actually for this inguinal area. And you want to be sure that you're palpating for any lymph nodes, making sure that you're ruling out any infection in both the popliteal area and in the inguinal region. And then vasculature, venous, and arterial considerations for the lower extremity. So always checking for pulses. And then think about what you already know already with Mitchell model and zinc that can lead you to be able to treat patients with lower extremity complaints locally and globally. So you already know how to do diaphragm release, and you already know how to treat using Mitchell model, which is going to help to open all this area up for these lymphatics, for the vasculature, by doing your Mitchell model, by doing your zinc screen. So you already know a lot of things to do for the lower extremity. The integrated exam always begins with a history. So you have your questions that you ask just as you would always ask your questions previously. Adding a little bit more questions about, are you participating in any physical activity? And then you want to know if they've had any previous trauma, no matter what area. Because remember, even though they're having hip pain now, a severe ankle sprain can be significant. A significant, knee injury can be very significant. So you always want to get a trauma history. If they've had any imaging before, maybe they're having knee pain now, but they just had a knee x-ray last year and it was normal and this knee pain came back. But having that x-ray previously and knowing it was normal can be really helpful. I like to know if they've had any PT in the past and what was done, because PT can be a wide range of what you can have with services you can have done, from just having TENS unit and heat to getting manual medicine and doing really extensive retraining. So it makes a difference. Have they had any significant change in physical activities, in their job, in their shoes, other ergonomic factors? And then think about those intrinsic factors that we talked about earlier and ask them questions about, how might some of those be playing into the history? Have they had any increase in stress, anxiety, and depression, recent change in health status? And your review system should help to rule out any referral pain from any pelvic or abdominal causes, as well as things that might point you, down along the line of infection or cancer, right? So ruling out, fevers, chills, night sweats, weight loss, pain while sleeping. That's those sort of red flags. So let's begin with the hip and thigh evaluation. So you're going to see for each area, hip and thigh, and then knee, and then ankle foot, we're going to run through the same sort of thing. So we went through the overview, and now we're going to have a little bit more specific, how would we do it for this area? So looking at gait, is there a Trendelenburg gait, meaning that, does the hip drop to one side, indicating a glute medius weakness? Do they overpronate? Do they supinate? Looking for that anterior posterior pelvic tilt, which can actually put strain on the femoral head. You're going to observe. So when I have people come in with hip pain, I have them put on paper shorts because I want to take a look at that hip. I want to see if it feels swollen on the lateral aspect. And in the history, that's where, you really need to know, even for hip pain, is it in the groin? Because the groin means true joint pathology versus the outer hip is like the greater trochanteric region, versus the posterior hip is more like SI. So you want to get a good feel for where is their pain and what do they mean by hip, because what they mean by hip might be a different thing than what I mean. So they have to point to where it is. Then I palpate, and again, I'm palpating all those muscles. I know what's under my hands. I know what lives there. So adductors, iliopsoas rectus femoris, the internal and external rotators, the greater trochanteric bursa, the TFL, your Mitchell model considerations for sure. You want to palpate all of those things and think about the muscles that are attaching there. Active and passive range of motion, you're going to check internal range of motion, external abduction, adduction, flexion, extension. So those are the gross ranges of motion that you want to check and compare from side to side. And always remember to do the joint below as well. Vascular, lymphatic, femoral pulses, inguinal lymph nodes, special tests. We're going to go through a few of these. I know a few you've had before, a few you haven't. Structural exam, Mitchell model, lower cross. And then somatic dysfunction of the hip. So this is a minor motion, and it's going to be femoral acetabular glide. So for the joints, we have glides and we have slides, right? So you have gross range of motion, and then you have this more subtle range of motion, which are the glides and slides. And femoral acetabular glide will be the first one we talk about. Then we want to assess for any somatic dysfunction, lumbar tender points, trigger points, Mitchell model. And then we want to, think more globally, assessing for the ABCs or zinc or postural considerations. So our special test, I know you guys have had Faber before. This is your figure 4, right? And when you press on the figure 4, if you have pain in the anterior hip region or in the groin, that's more positive for true hip joint, versus posterior pain can be for the SI. So hip impingement and hip scour, I believe, are new for you. So basically, you are looking to get grindy of that hip in the actual capsule and on the labrum. So hip impingement can help you to identify if there's femoral acetabular impingement, which we'll describe in just a second. But basically, the patient is supine, you flex the knee and the hip to 90 degrees, and then you adduct and you internally rotate. So you're really driving the head of the femur right into that socket, right? And so if there is an impingement issue, that will create pain. The hip scour test is almost the exact same thing, and this can really look at the labrum, capsulitis, osteochondral defects, osteoarthritis, avascular necrosis, and femoral acetabular impingement. So it's the same thing. The patient's supine, you flex the knee, you adduct to the hip, and then you apply a downward force on that femur. And then you, as you adduct, you externally rotate and you internally rotate. You scour it around. You're looking for any issues with the head of that femur inside the acetabulum itself. We're going to practice these in lab. And then there's the Aubert test. You guys have had that one before. That's checking for the IT band. The patient lies on their side, and you take the top leg and drop it behind, and you're looking to see if it can drop down. If not, it might be a hypertonic IT band. And then Thomas test. We do this one all the time, sitting at the edge of the table, dropping one leg off, lying back, and checking to see, as we learn in lower crossed, we can identify issues in iliopsoas, rectus femoris, and the IT band. And then we have our subtle motion, the femoral acetabular, via the gliding. So you can see the bottom hand is wrapped around under the thigh to get a good hold. And then here, it's like you're feeling for the head of the femur. So you're kind of trying to get your fingers around either side right here. And you're gliding it in this superior lateral versus inferior medial and anterior lateral versus posterior medial. And those are kind of complex motions to think about, but really what you're doing, thinking about how this ball moves around in this socket, right? And those are the motions. And you're assessing for end feel. Is it articular? Is it myofascial? And then often this is the exact same way that we're going to be treating it. So as you diagnose it, you can treat it with BLT myofascial release, which we will discuss in that lecture. And then don't forget your lower cross syndrome and evaluation for trigger points when you're thinking about hip pain. There's lots of trigger points that can refer in particular patterns that make you think hip pain, but it's really just a trigger point. So doing your adequate palpation, really looking for where that point is tender and starting to get an idea of where these trigger points radiate to. So, like we're looking at the trigger points here for iliopsoas, and we see that the pain is here. So when someone comes in with back pain in this region, you need to go looking and poking around for these trigger points, right? So a few common hip overuse syndromes, and I'm not going to go into a lot of detail for many of these because I think that you've had quite a few of them before in your lower extremity chapter with doctoring, but we will run through some considerations. So the first is iliotibial band syndrome. So this is abnormal tension in the iliotibial band, can irritate the bursa at the lateral femoral condyle, and it's really common. So usually they get pain in the lateral knee. It can be also in the lateral thigh or the side of the hip. The pain can be greatest at heel strike, and mostly this is a history and physical exam sort of consideration. You can do the Aubert test, and you really want to look at their biomechanics of the other joints, the knee, the ankle, the foot position. Is there somatic dysfunction? And is there glute medius weakness, right? As we learned in lower cross syndrome, when there's glute medius weakness, iliotibial band tries to take over, and that's really not its job. It's not strong enough to do that. People usually get iliotibial band syndrome if they've had an increase in activity, running up and down hills. If they are knock-kneed, they typically have it more often. If they're running long distances, if they're running on banked surfaces, cycling or rowing, and if there's a leg length discrepancy. And then keeping in mind some of the biomechanics of this. So foot, if someone has supination, it increases the lateral knee pressure. Or if there's overpronation. So you have to look at both sides. It's not really one or the other. It's just abnormal biomechanics. And there's just a different way. So supination causes lateral knee pressure versus overpronation causes medial tibial rotation and torsion, which increases lateral knee pressure. So it's just a different biomechanical way of irritating the same thing. Knee If someone has more of a valgus sort of strain, it can tighten the IT band, but also verum can cause lateral femoral condyle to be more prominent, causing friction. So again, abnormalities in alignment, abnormalities in biomechanics. And then the hip, glute maximus and tensor fasciae lata can pull tension. So if someone's glute max is tight or has issues, we learned in lower cross that glute max is usually weak. And then glute medius weakness can lead to inward rotation of thigh and valgus stress, leading to that IT band. And we know things that we can do for all of these things, right? How we can dress lower crossed, how we can do stretches, and how we can do muscle retraining. And that can be really helpful for people with iliotibial band syndrome. So treatment is usually RICE. If they have a short leg, you're thinking about heel lift orthotics or appropriate shoes if they are having some sort of gait disturbance. We want to address their faulty biomechanics of the spine and the pelvis and lower extremity using Mitchell model. We need to talk our patients into avoiding aggravating activities, just waiting until the pain resolves. It's hard to do when you're a runner and you're not allowed to run, but good things can happen. I had my first running injury, and that was when I really got into yoga. So it can all be good for a good reason, and you just have to convince your patients to do that. They can stretch or do self-massage. Foam rolling is great, especially for tensor fasciae lata. They can do glute medius and maximus retraining. You can do a steroid injection at the site of the bursa, but remember, you don't want to inject steroid directly into tendons. It can cause tendinous rupture. And there was a case report written in the JOA of a guy who saw someone, one patient, and treated them with OMT who had IT band syndrome, and they got better a lot faster. And basically all they did was counterstrain. And that's super easy. As depicted in the picture, you find that greater trochanter and you kind of just side bend around it. Basically, you're doing abduction until the pain turns off, and that can be really helpful for that. So more overuse syndrome. So these are other things, hip pain. And again, I don't want to go into too much detail. That's not what this lecture is about, but just to give you some ideas of why we're doing these tests, why biomechanics matter, and how OMT can help. And again, location, location, location. So sacroiliitis is going to be inflammation of the SI joint. So if someone comes in and they have kind of a posterior hip pain, you want to consider that. I also, consider glute medius, glute maximus, trigger or tender points. Pelvic and femoral neck stress fractures, so people who are doing high mileage, high volume activities or who have risk of osteoporosis. Osteitis pubis, inflammation of the pubic symphysis and surrounding muscles. Again, they're going to point to their pubic region. Trochanteric bursitis, so inflammation of the bursa. Hamstring strain, so that can be at the, ischial tuberosity region, the strain at the origin, not at the insertion. Glute medius and minimus strain or sprain. Again, that's going to be attaching out at the greater trochanter, so can be confusing with trochanteric bursitis. Popliteus tendinopathy, which is kind of more of a knee issue, but inserting on the lateral femoral condyle hurts more with braking on the downhill, and the fibula will produce pain at the lateral knee, so a little bit more knee than hip. Iliopsoas, bursitis, and tendinitis. A lot of people forget about this one. So there's a bursa there. As your iliopsoas combines with your iliacus and crosses, over to get to that lesser trochanter, there's a bursa there, and that can become inflamed and tender, and it can actually have snapping. So people will complain of snapping with IT band syndrome on their lateral hip. They can also get snapping at their medial hip groin, and it can be due to either this tendon or the bursa. And then a sports hernia, which is a strain or tear of either abdominal wall musculature or adductors, and it's very tender at that attachment at the pubic bone. And then less of an overuse syndrome, but it can become aggravated when it wasn't aggravated before by doing repetitive activities, and that's femoral acetabular impingement. And this is important to diagnose because it can lead to early osteoarthritis. So there's two different types. The first is called CAM, and CAM means that there's a non-spherical femoral head. So you can see here it's round, but here it's not really round. There's like more bony area to this femoral head. Pincer is where there is more acetabular covering. So you can just see this would lead to a pinching action here. This would lead to a pinching action here because there isn't, like basically a groove for it to fall into. And mixed can have both. And these are reasons why you want to do that hip scour test and why you want to check the hip impingement test to see if people have these sorts of issues. And these, you can get X-ray, CT, MRI, or MR arthrography. Labral tears, you really need to get arthrography. Labral tears are often post-traumatic in young adults, so more of an injury rather than an overuse, but degenerative in older population, and you can't see them on plain films. So you can start to deduce that you have an issue there by doing the hip scour or the hip impingement, but you really need to get a little bit more advanced imaging, and MRs are not comfortable, so you need to warn your patient of that. So moving on to knee evaluation. So again, going back to the same consideration, what do I do first? I look at gait and posture, always starting with gait and posture. Overpronation, oversupination, high arches, low arches, knees hyperextended, how are they moving in space? And then I'm going to inspect it for warmth, edema, erythema, tenderness, deformity, and alignment. I'm going to make notes on all of those things. Active and passive range of motion, muscle strength testing, that's pretty easy. It's just flexion or extension. And then I'm going to palpate. Again, know what lives there. I'm going to feel the joint line, the ligaments, the patella, the muscular attachments, the bursa, the tibial plateau, the tibial tuberosity, the fibular head, the patella, and the attachment points of the iliotibial band, hamstrings, quads, adductors, pes anserinus, patellar tendon, and ligaments. Vascular and lymphatic, popliteal and femoral pulses, inguinal and popliteal lymphatic nodes. And then my special tests, which we'll go through really quickly because I'm pretty sure that you've had most of those already. And then somatic dysfunction of the knee. So gross range of motion, flexion, and extension. Your glides and slides. So there is a tibiofibular motion, which is going to be anterior lateral and posterior medial. There is a tibiofemoral motion, so the tibia on the femur. So that has internal and external rotation and an anterior-posterior glide. And then patellar motion. You can take that patella and you can move it medial and lateral, superior and inferior. So those are the glides and slides of the knee. Pretty easy. Don't forget to assess the joint above and below. Your structural exam. Somatic dysfunction of the area. Again, tender points, trigger points, dysfunction of the tibia, fibula, and patella. And your somatic dysfunction globally. Checking for your ABCs and your zinc screen. And here are some pictures of some of the tests. So milking for effusion, ballottement, looking for edema, patellar grind, you're pressing down on that patella and then having them contract their quads, which I feel like never feels good, even if you don't have an issue. And then patellar apprehension, pushing that patella to either side and seeing if that makes people crazy. Tibial sag signs, you can see the positive one, the tibia is sagging posteriorly, which tests for the posterior cruciate ligament. And you can see where it's negative, there's a nice straight line there. So that's an important sign. Apley's compression and distraction. Obviously, as you compress into it and twist around, you're compressing onto the meniscus and, trying to catch any little meniscal tears there. If you're distracting, you're going to be testing the ligaments, so the medial collateral and the lateral collateral. So that's a good test to help kind of rule out. But don't forget, if people have somatic dysfunction, it can give you these false positive sorts of considerations. And I know you guys have had anterior and posterior drawer already. Anterior drawer looking at the ACL, and checking its integrity. The posterior drawer, looking at the PCL. Lachman's, which is considered to be more sensitive, you're stabilizing and pushing down on the thigh while you're pulling the lower extremity towards you and looking for that gapping motion. And what I want you to think about while we're talking about anterior and posterior drawer is this can also be used to assess somatic dysfunction, right? That's going to be that anterior and posterior glide of the tibiofemoral joint. Okay, so it's much more minimal. It's not like laxity. It's just you're noticing there's a slight difference from side to side. One side feels a little bit more posterior or a little bit more anterior than the other side. McMurray's, again, this is checking for the meniscus. I see people do this wrong all the time. You need to be monitoring at that joint line. You have to apply the valgus stress, externally rotate the leg, and extend the knee, right? And then for the lateral, it's varus stress. You're going to internally rotate the lower leg and then slowly extend the knee while it's in varus. So you're really trying to squishy and compress as much as you can. You're rotating, you're creating this stress on the meniscus. You're trying to catch it and see if you can cause it to click or move. So a positive test is pain and or click at the joint line. And sometimes when you're doing this, you'll feel clicks somewhere else. That's not a positive test. The click has to be, you're looking for that meniscus click. Sometimes as you do this, you get the ITBN to snap or an adductor snapping, not the same thing. Varus and valgus stress test. Again, valgus stress test is going to check the MCL. Varus stress test is going to check the lateral collateral. The thing that I see people do most often is they only check it in 0 degrees when the leg is locked out. And, you want to check it at 0 degrees because if there's gross instability, that's where you'll catch it. But really, you need to check it at 30 degrees. So don't forget to do that. I will mark you off for it. And also note that this is the counterstrain position. So you're wrapping right around that point for the opposite side. So when you're doing the medial collateral, see you're gapping this side, but you're wrapping around the lateral collateral side. So that's actually a counterstrain point for that. Same thing here, you're putting a stress and you're gapping at the lateral collateral, but you're shortening around the medial collateral. So that can help you to remember what those counterstrain points are that you're going to get a few lectures from now. And then assessing for somatic dysfunction of the hip, thigh, and knee region. Right, so globally, looking at their posture, sitting and standing. So are they doing a lot of one-legged standing? Because that can cause issues. I think I've told everyone my story about how I was having hip pain, and I went to see a lot of good osteopathic doctors, and they treated me, and my hip pain always came back. And then I was just standing there one day, and one of my preceptors said, "You're having hip pain, don't stand like that." And I realized I was doing all one-legged standing, and as soon as I stopped standing like that, my pain went away. It was pretty amazing. So I just needed someone to notice what my posture was. And I'm going to harp on it over and over. Pronation, supination, arches, muscle imbalance, shoe wear, proprioception. You've got the basics down. Now start putting it together. What is causing this issue? Don't just diagnose it. Figure out what's happening. And then articular. So these are what we went over already. Your tibiofibular motion, your tibiofemoral motion, your patellar motion, and your femoral acetabular motion. So your glides and slides, and that's what we're going to be going over in lab, and those are all excellent test questions. And then muscular, tender points, trigger points, hypertonicity, weakness, and balance. Ligaments and tendons, palpate for laxity or hypertonicity. I know you guys had the prolotherapy lecture already. So as you're palpating those tendons, is there laxity there? Is there tenderness directly at the attachment site of the ligament to the bone? And those are places where you can do prolo, and it can be really helpful. Fascial restrictions, interosseous membrane, you're thinking about your autonomics, and your lymphatic vascular to help with the healing process. So thinking about how you're going to integrate all this stuff, and it gets really fast. If you're practicing doing it when you're doing your palpation, you're going to get very good at it very quickly. So common overuse syndromes of the knee. Patellofemoral syndrome, very common. Clinical diagnosis, no specific sign or test. It's really super common. Adults and adolescents, women, especially women who do a lot of running. And it's worse with running, squatting, or prolonged sitting, and they call that moviegoer sign. Why? Because you're putting stress right over that patella. You're compressing it directly against the femur for a long period of time. I totally have moviegoer sign all the time. I hate going to the movies because my knees hurt so bad. It's poorly localized. People, when they have patellofemoral syndrome, they'll usually grab right over their knee. They'll say, my knee hurts. They'll grab like the whole thing. They won't necessarily point to a specific area. It's gradual, or it can be gradual or acute. Sometimes they'll have reports of buckling or giving way, and there may not be trauma associated with it. There are acute phases. It's always great to have people modify their activities. They can consider NSAIDs, but it's usually tendinopathy rather than a tendinitis. And OMT is great for this because you're going to be treating things that are, affecting that biomechanical imbalance. Let's see. There's no single rehab protocol supported, but a lot of it has to do with core strength and considering physical therapy. So generally you don't get x-rays if there's no instability, no pain at rest, no effusion, no trauma, no history of surgery. But if it's a period of time and it's not getting better, then you would want to consider getting some sunrise views to see if there isn't like a little foreign body in there or some type of osteochondral defect or something like that. But generally you can just treat conservatively. And when you're thinking about patellofemoral syndrome, there's a lot of mechanisms that play into this. So again, don't just diagnose patellofemoral syndrome. Figure out what's going on. So a lot of it can be malalignment, leg length discrepancies, patellar hypermobility, lower extremity muscle imbalance, large Q angle, which is demonstrated over here. I'm not going to test you on how to measure this, but people who have a little bit more knock kneed or who have wider hips tend to have a large Q angle, and they have a higher likelihood of having patellar maltracking and patellofemoral syndrome because it's hard to keep that patella in that groove versus people who have a smaller Q angle. And I think this is why women have it more because we have a wider shaped pelvis and typically a little bit more hypermobility as well. Vastus medialis weakness was the big thing for a while, and they still think it contributes. So one of the quad muscles, which helps to keep the patella in that groove. Innocent biomechanical abnormalities, muscle inflexibility, hamstrings, quads, hip flexors, quads specifically rectus femoris, and glute medius weakness. Right, so again, that's going to cause our bodies to move in a different way. IT band's going to take over. It's going to cause internal rotation. That's going to put a lot more patellar maltracking this way. But there are lots of other common overuse syndromes of the knee. And again, I don't want to get into all of these a lot, but just some things to be thinking about. What lives in that area? So you have pre-patellar bursitis, infrapatellar bursitis, patellar tendinopathy or jumper's knee, chronic patella subluxation, and that's where that kneecap just constantly subluxes out of its groove. Pes anserine tendinitis, so medial knee pain just slightly below the knee itself where that pes anserinus is. I've actually injected a few bursitis there with some really good effect. Osgood-Schlatter is the apophysitis of the tibial tubercle. This happens in kids. Sinding-Larsen-Johansson syndrome. That's a good one to impress your attendings in. With. It's basically the same thing as Osgood-Schlatter, except instead of the apophysitis happening at the tibial tubercle, it's happening at the inferior pole of the patella. So again, that happens in kids and is just a fancy one to show your attending that you know what you're talking about, or that you think you do. Quadriceps tendinopathy, and then medial plica syndrome. So plica is an extension of the synovial capsule, and it can become irritated or inflamed, and especially if this patella is rubbing over it, and they can remove that via surgery. So just some other things to think about that are a differential diagnosis of patellofemoral syndrome. And again, a lot of these, you're not really going to do anything about it specifically. Even for the bursitises, most of them you're not going to stick a needle into it because your risk of giving someone infection in their joint space is much higher than the pain that they have. And what they really need to do is rest and have their biomechanics evaluated. So finally, lower extremity, ankles, and feet. The integrated exam of the ankle and foot. So same thing as before. We're going to go over it again. It's like a pattern. And when you practice things in a pattern, you get better at it in a pattern. So you're going to look for gait, overpronation, supination, heel walk, toe walk. How is their knee hyperextension? What's their shoe wear look like? You're going to inspect for warmth, edema, erythema, tenderness, pulses, deformity, alignment, and positioning at rest. Vasculature and lymphatics, just as we did before, and active and passive range of motion and muscle strength testing. Again, these are going to be your major motions of the ankle and of the foot. And then you have your minor motions, and these are the big ones that we want to look at, and that will be important testable material. So you have your talocalcaneal motion, which is going to be your inversion and your eversion. Your tibio-talar motion, which is plantar flexion and dorsiflexion. And there's also going to be anterior and posterior glide, so your subtle motion. Your glides and slides. There's going to be cuboid motion, which is inversion, eversion, dorsal and plantar glide, and then phalangeal motion, dorsal and plantar glide, inversion, eversion, and medial lateral. So think about taking that little phalange or the metatarsal, and you can glide it dorsal and plantar, so up or down. You can rotate it in inversion or eversion by rotating it, and then you can move that toe or that metatarsal back and forth into medial or lateral. So people often get that wrong on test questions. Although a major motion can be toe extension and flexion, your minor motions are dorsal glide, plantar glide, inversion, eversion, and medial and lateral glide. These are all glides. And then you want to palpate, and I'm not going to go into this in detail because we did in the podiatry lecture. It's still fair game for these tests as we think about, what attaches there, what muscles from the lower extremity come down and attach there that could be causing tenderness. And then we're thinking about our special tests, which we'll run through. You always want to think about the joint above and below. Your structural exam, same as before, looking at somatic dysfunction of the area, tender points, dysfunction of the tibia, fibula, talus, and foot, as we just described, your minor motions, your glides and slides, soft tissue, articular, myofascial, and then your ABCs, zinc, and proprioception. So thinking globally, how is this affecting everything? And what do I need to treat globally in order to affect this issue? So first we have the Thompson test. This is, you're going to squeeze the gastroc, and what should happen is that the foot should plantar flex. If it doesn't, you might have a full rupture, which is a bummer. This is usually a traumatic event. This is an overuse. They could have Achilles tendonitis, but they should still have function of their foot. So this is how you could differentiate an acute Achilles tendonitis flare versus an actual rupture of the tendon. But most people, if they have a complete rupture, they will know it. They will come in and say they thought a dog bit them in the ankle or they got shot in the ankle. Like it makes a loud noise, and they generally really know it. The squeeze test, this you can think about it as two different ways. So first is squeezing the tibia and the fibula more proximally, and you're going to squeeze as the patient dorsiflexes their foot. And this is going to cause the distal tib fib to gap a little bit. And if there is pain there, it suggests tibiofibular syndesmosis injury, right, or a high ankle sprain. You can also squeeze at the calcaneus, so you get your thumb and your first finger around that calcaneus and squeeze, apply compressive force. Pain is a positive test, and you'd really need to rule out a stress fracture, right, because you're squeezing at the bone, and so that's what's causing the irritation, so that's no good. And then the windlass test, again, we talked about this in the podiatry lecture, but you're basically having the patient standing, and you produce you forcefully extend their great toe, and a positive test reproduces pain at the medial calcaneal tubercle, so at that plantar fascia. This has a very high specificity for plantar fasciitis, but a very low sensitivity, something like only 31%. So if the test is not positive, that does not mean that they do not have it. And then we're going to do tests for tibio-talar joint instability. So anterior drawer test, right? So we're trying to slide it forward to see the stability of the ligament. but also we can use it to evaluate for somatic dysfunction. So remember we talked about the motion here was dorsiflexion and plantar flexion, but also there was an anterior posterior glide and slide. And so you can do this to check for ligamentous stability, but also what is the subtle motion. And then same thing with the talar tilt. We're looking at, the integrity of the calcaneofibular ligaments here, and if someone has an acute ankle sprain. But if someone just has chronic pain, it's not acute ankle sprain, you're still wanting to evaluate that joint and looking at its motion in inversion and eversion. And is there dysfunction from side to side? And not just which side is restricted, but also which side is lax, right? What if somebody has had a lot of chronic ankle sprains? It can actually be the lax side that has the most problems. So common overuse syndromes of the lower extremity, ankles, and feet. So medial tibial stress syndrome or shin splints. This is usually pain along the tibia due to stress on the bone and the connective tissue. This is usually overload of the lower extremity muscles and or due to biomechanical dysfunction. Happens with runners or any time of sports players that do sudden stops and have a lot of pressure applied to their legs. And in increasing any activity too rapidly can lead to muscular fatigue, decreased capacity to absorb impact and shock, tibial bending and bowing, and then medial tibial stress syndrome. It can also be due to tightness of gastrocnemius, soleus, and plantar muscles can contribute to this. So you got to think about agonists and antagonists and, tightness of the whole lower extremity. And diagnosis is based on history, so you really need to think about medial tibial stress syndrome versus stress fracture. And neither of them are seen on x-ray. So you need to think about that, and then you need to think about, do they need a bone scan or an MRI if you really think that they have a stress fracture. So typically for shin splints, they're going to rice, they're going to NSAIDs potentially, no provocative activities until the pain subsides. You want them to stretch, potentially use kinesio tape, decrease weekly mileage and running on hard surfaces, and you're going to address the biomechanics with OMT and do shoe change. And then here's a little chart over here about how you can help differentiate compartment syndrome from stress fracture from shin splints. And a lot of it's going to be focal severe pain at the bone versus diffuse achy pain. Response to running, it'll be pain before, during, and after, versus sometimes it gets better here. So it is kind of hard to differentiate between, but usually with stress fracture, it's more of a prolonged pain versus you're not having pain with just the shin splints when you're at rest, unless you're really in the advanced stages. And then just quickly keeping in mind the difference between sprains and strains. So sprains is going to be that injury or stretching or tearing of a ligament or joint capsule, versus strains is going to be injury, stretching, or tearing of a tendon or muscle. And you can have pain and even some weakness and muscle spasm. So just thinking about, a lot of times I feel like students have a hard time coming up with a differential diagnosis when it could be sprain or strain pretty easily. We forget about the easy ones. And when we talk about ankle sprains, I know you guys have had this before, so I'm not going to belabor it. Most of it's from inversion, plantar flexion. There are lots of ankle sprains, so you need to know how to diagnose and treat an ankle sprain. There's lots you can do with OMT. And the most common ligaments involved: anterior talofibular, calcaneofibular, and posterior talofibular. Anterior talofibular always tears first. That's a great one for boards, and understanding why ankle sprains happen in plantar flexion versus dorsiflexion, because it's more stable in dorsiflexion. Here's the grading of the sprains. That's always a great test question and great boards review question, is just understanding, what grade level would you call it and what do you need to do about that, because at grade 1, you don't really have to do a whole lot, and at grade 3, they might need further stability because they don't have any stability there. So making sure that you know what those are. And then the Ottawa ankle rules are always critically important because they help to reduce x-rays and they help to identify ankle or midfoot fractures, which is really great. And there was a study for OMT for ankle sprains in the ER, and they did this in the ER, which I think is fantastic. You know, you can treat people in ER as well. They did some really simple techniques. And what they found was that people who just got one session of OMT in the ER group had significantly improvement in edema and pain and a trend towards increased range of motion immediately following OMT. So they felt better about it, so that's good. But they also had them follow back up at the ER a few, I don't honestly remember how long it was later, if it was a few days or if it was like a week. But the OMT group had statistically significant improvement in range of motion compared to the group that didn't get OMT. And that's after one treatment. So yeah, we need to have some further studies. 18 people isn't a large population, but I think that's really interesting, and it just shows you that you don't need to be in a big research center to do research on OMT or to treat your patients well. People say they don't have time to do OMT in the ER. You totally do. Take care of people, help them feel better. Syndesmotic or high ankle sprains. We talked about the squeeze test already. And these are much bigger problems, much more unstable, and you don't want to miss them. They can be associated with sports trauma and commonly associated with fibula fracture. So you can see on the x-ray here that there is a gapping of the joint here because of the instability, and then the fracture here. So you want to get an x-ray of the whole way up just in case someone's got a spiral fracture. If you think they have that high ankle sprain, you don't want to miss that. And then common osteopathic findings in supination ankle sprain. So you want to look for tender points. You want to assess any areas that would impede lymphatic drainage. You want to think about all the things that happen to that patient. Like, how did they go down, right? If someone really sprained their ankle, they didn't just twist their ankle. Like, they did some sort of weird contortion with their body as they were trying not to fall. And how are you going to address all of those things? How can you make all of those things better and help to support them while they're healing, because they're going to be walking kind of funny for a little while. You can also get them doing early range of motion with alphabet, and I probably should have highlighted this, but proprioceptive retraining when they can stand without pain, right? Critical, just like we talked about in the lower crossed syndrome lecture. Chronic ankle instability is a big problem, and some of you may know this if you've had a lot of ankle sprains in the past. You can get instability. You sprain your ankle over and over again. Very common in athletes who have had a lot of sprains. You get loss of proprioception, so you don't know where your ankle is in space, and you sprain it again, and those ligaments are never the same. And these people who have a lot of chronic ankle sprains are at much higher risk for overuse injuries down the road, earlier arthritis, and earlier injuries, which is a big problem. People who have poor tissue repair, so smokers, diabetes, chronic disease, lack of lymphatic movement, maybe they have congestive heart failure and they have a lot of edema, those people are not going to get better from their ankle sprains. So you really need to think about OMT with them and about getting all that edema out of there so that it can heal properly. And then getting them rehabs. So lack of motion for too long, lack of proprioceptive retraining does not help ankle instability. You want to use OMT to address regional, postural, lymphatic, vascular, so ABCs. Probably even get them into physical therapy, get them bracing or NSAIDs. Consider prolotherapy if there's a lot of laxity there. Prolotherapy has been shown to have some good benefit with ankle instability, or PRP. And then some people go on to have surgery to reconstruct those damaged ligaments. The other thing that I want you to think of, I think it's funny that this just happens to be a picture of Tiger Woods, which maybe you couldn't tell because the picture is short and squat and I sized it weirdly. But anyway, he is in a walker boot, right? So just think about what's that doing to his posture? Like how much length is that adding to his leg? So essentially he's got a really long leg that he's jamming up into his back. Like how is his back going to feel? What are the postural consequences of walking with crutches and he's not getting a lot of bend into his knee? Like he's changing everything. Think about how that's affecting the sensory motor system as we talked about in lower crossed. Think about how that's affecting tensegrity, right? How it's affecting his gait and what he's going to have to do to get that back, right? So there's a lot more going on than just sticking someone in a boot and hoping that it heals properly. They actually need a lot more care than that. And then moving on to plantar fasciitis, we talked about this a little bit already in the podiatry lecture and thinking about the windlass mechanism, but is irritation and inflammation of the plantar fascia. People aren't really sure why, but it usually happens with increase in mileage, poor shoes, hard running surfaces, usually in people age 40 to 60. And then sometimes a heel spur coexists. And I think it's funny that, like traditional medicine doesn't really understand why that might happen. And, they are not looking, they're not thinking about the structural versus functional lesions like we talked about. So structural lesion, heel spur. Functional lesion, why is that heel spur there? Well, there's abnormal tension on that plantar fascia tugging on the calcaneus. Wolff's law is going to lay down bone right there. So that's not a question in my mind whatsoever. It's called physiology. Risk factors, obesity, unsupported running shoes, high mileage, being female, prolonged weight bearing, advanced age, pes planus or cavus overpronation, mechanical dysfunction of the foot or ankle, decreased ankle dorsiflexion. So again, biomechanics that we need to look at and assess, are they different? Plantar fasciitis, so you can differential diagnosis. It's always the worst and the first few steps in the morning, versus like if someone has a calcaneal stress fracture, it should be better when they get up in the morning. It's worse as they walk further. First line treatment, rest, avoid barefoot walking, avoid flip-flops like we talked about in that podiatry lecture. Consider ice. I like people to do stretching of their gastroc, rolling out their plantar fascia, foot taping. They can wear gel cups for their heels for their plantar fascia. Second line treatment, night splints to help maintain that ankle dorsiflexion so it doesn't get shortened during the night. People do steroid injections. There are risks with that. You can get heel pad atrophy with a steroid injection, but I know some people, I don't do those myself, but I'll send people to podiatrist if they need a steroid injection. The idea of injecting people's feet gives me the heebie-jeebies. And then some people go on to have surgical release of their plantar fascia, and those are people who have had really intractable pain. They've tried the boot walkers, and really nothing has helped them. And again, I wonder how much of that is not looking at the functional lesion and just diagnosing and trying to support the plantar fascia without, supporting or addressing the biomechanics that go along with that. Plantar fasciitis differential diagnosis, we already did this in the podiatry lecture, but here it is again. Painful heel pad syndrome, calcaneal spur, calcaneal stress fracture, atrophy of the fat pad, and then somatic dysfunction, right? So restrictions in the midfoot, hindfoot, forefoot, tender points, fascial restrictions, lower cross considerations can all mimic plantar fasciitis. And we've made it to just a few final thoughts. Don't forget about referral pain. So pelvic and abdominal causes can cause referral pain into the lower extremity, especially into the hip area. So you want to be sure that you do your GI evaluation. Dermatomal referral patterns, as we have over here. So is this actually a disc issue and you've got an L1 or an L2 referral pattern? You don't want to miss that for sure. Sclerotomal referral patterns, so ligaments themselves, lumbosacroiliac, lumbar, posterior sacroiliac, and where the ligaments refer to, those are sclerotomal referral patterns. Myotomal referral patterns are muscular referral patterns. Peripheral nerve compression issues, so not forgetting about lateral femoral cutaneous, genital femoral, ilioinguinal, anterior femoral cutaneous. So these cutaneous nerves that are supplying sensation, that they won't necessarily have any motor involvement, especially lateral femoral cutaneous, but people get numbness or tingling and they'll complain of lateral hip pain. Radiculitis, radiculopathy we talked about. So seeing if there's a neurological deficit and thinking about the mechanism of injury, and then provocative testing. I always do a neuro exam in my patients who come in with lower extremity complaints. I don't want to miss anything. So this lecture focused on lower extremity overuse and some acute trauma issues that happen in these regions, but don't forget other important differential diagnoses. So even more diagnoses if there's trauma, a lot more fracture considerations. Inflammatory arthritises, rheumatoid arthritis, ankylosing spondylitis, that sort of thing, osteoarthritis, avascular necrosis of the hip, infections, tumors, nerve entrapment, fracture, dislocation, bony contusion, meniscal injury, and DVT. So lots of other things that you want to think about in the lower extremity. Again, not what we focused on today, but also didn't want you to forget about them. And then how can OMT help patients with lower extremity complaints? Well, it helps circulation and lymphatic flow. So if you have a lot of edema or a lot of stasis, that's going to lead to an abnormal intra and extracellular environment, which actually leads to fibrosis and adhesions. So I will usually tell people, when they first injure, if they have like an acute ankle sprain, I'll tell them to take an NSAID for maybe the first 24 hours just to help get that edema out of there. But after that, I want them to stop. Once that edema is out and I've helped to clear the edema out, it's useful in the beginning and then it's not useful, right? And then I want them to stop taking the NSAIDs because there's actually some evidence that shows it delays the healing process. So you want to remove the edema from the injury and have the ability to heal through proper circulation. So somatic dysfunction can cause pain, dysfunction, and complaints in and of itself. So it can be the primary cause. It can affect lymphatics and circulation, biomechanical issues, and how are they compensating for that altered gait? Right? So if someone's had ankle pain for a long time, knee pain for a long time, hip pain, they're going to start changing the way that they move so that they're not affecting that pain. Runners will run through pain for a long time, but they'll have these slow changes in their gait, and then they'll start to have other problems, right? So you're addressing not only the issue that's going on, but how it's altering and how they're moving in space because of that injury, and you can help them with that. You can help their economic efficiency, right? The nervous system, you're thinking about sympathetic, parasympathetic balance, and then nociception. Critically important, not just because the patient will feel better if you address their pain, which is fantastic. You'll decrease their allostatic load and help their healing overall. But don't forget, that nociceptive information is part of the sensory motor system, just as we talked about in lower cross and upper cross. So when you have a lot of nociceptive information pouring in from these afferents, it's going to change the way our muscles fire. It's going to set up different firing patterns, and it's going to change the way that we move. And so decreasing this nociceptive drive can help to diminish that process and help to restore normal motion and normal proprioception. So that's why it's so critically important. You're addressing things down the road by treating pain. And OMT sets the stage for healing overuse injuries. So it alleviates biomechanical issues, weakness, hypertonicity, decreases local swelling, improves pain, improves fluid transfer, decreases the need for pain medication, which is a huge issue these days, and improves the ability to compensate for the injury. And if you give them stretches or exercises, it gives them a way to be part of that healing process as well. Contraindications to OMT in the lower extremity: directly over fracture site, infection, DVT, compartment syndrome, acute emergent situations, complete ligamentous or tendinous rupture, and lack of somatic dysfunction. So, generally OMT is really safe and effective, and especially you can use really gentle techniques like BLT, myofascial release, LER, counter strain. And even if you can't, so say someone does have a complete tendinous rupture of their Achilles tendon, right? You're probably not going to do anything to that Achilles tendon, but can you do a popliteal release? Can you do a diaphragm release, right? Can you treat T12 through L2 to help decrease sympathetic tone? Those are all things that you can do to allow you to do OMT and still help this patient's physiology to help them heal better, faster. And that is the end of the lecture. So I'm looking forward to seeing you guys in my TBL and in lab when we're going to practice putting a lot of these physical exam skills together. Thanks so much.